this important session. I'm particularly delighted because we are a member of the M8 Alliance that sponsors the World Health Summit. And I'm even more excited because we are going to host the 2023 regional meeting of the World Health Summit in Washington, D.C. next year. Of course, I'm not making a plug for it, but I do want all of you to come to D.C. Next year in 2023. You're all most welcome. Ladies and gentlemen, this afternoon, we are going to be addressing a very, very important issue, an issue that some of us hope would never arise, but due to political conflict, sometimes natural disasters, man-made conflict, human race relations, ethnic conflicts, violence, humanitarian emergencies arise. People have to move. People get displaced, sometimes in their own countries, sometimes outside their countries. Unfortunately, the displacement sometimes affects the most vulnerable. Those who have less get even affected more. So they become even more affected. This means that the global public health community has to rise to the challenge in terms of their health needs, in terms of responding to the health crisis. We all know that public health is essentially political. So it's not just a health crisis. It is always a political crisis. And today I hope that many of our panelists will touch on this interface between humanitarian health, a health response, and of course, managing the political context of such responses. Ladies and gentlemen, we have very experienced people on the panel today. Their CVs will take me the whole session if I start reading them. So I will not do that. And I apologize to the honorable presenters that I will actually be very brief in my introduction. People here can read your bio sketches, but I think what we are all interested in is your insight as to how the world can do better with respect to humanitarian health, refugees, and our responses to them. I'm going to invite each speaker one by one, and actually I'm going to ask them to come and make their intervention, and then I'll invite the next speaker, and so on. That will make it a little bit more exciting, I think, for this afternoon. Ladies and gentlemen, my great privilege to introduce our first speaker, Dr. Ahmad Al-Mandhari. Dr. Al-Mandhari is actually the regional director for the Eastern Mediterranean Regional Office of the World Health Organization. And that's a position he's had over the most important 4 years throughout the COVID pandemic, leading the group of countries in that region. But Dr. Mandhari, of course, is very well known. He's a physician, worked in Oman, tremendous contributions to public health there. Dr. Mandhari, you have the added responsibility, not only of being a physician yourself, but now of leading the response across the Eastern Mediterranean Office. We would love to hear your thoughts on how to do better with humanitarian health, please.
Thank you very much, Adnan, for giving me this privilege and honor to be here with this great audience, talking about, as you have mentioned, a very important topic. In fact, just I'd like to give my remarks linked with some photos from the scene as a background. I would like to start my remarks by stating that, war and conflict have a drastic impact on health and development. We are all aware about the variety of these sort of impacts on health and development, like, for example, violent injuries, disease outbreaks in different locations, increased malnutrition, psychological trauma, sexual and gender-based violence, as well as disruption of health services and systems. And COVID-19 has just proven to us that sort of huge challenge that we are facing. And to be more specific and give you some, real life examples, fragile and conflict affected countries have the worst health outcomes globally. And I'll share with you the World Bank ranking. For example, 7 out of the 10 countries with the world's highest maternal mortality ratio are categorized as fragile and conflict affected countries. Similarly, 6 out of the 10 countries labeled by the World Bank as well is, having highest rates of child mortality. In addition to that, WHO estimates that 70% of cases of epidemic-prone disease occur in fragile and conflict-affected countries. In addition to what I have just mentioned, in fact, when we talk about the social determinants of health, it has been deeply negatively impacted by these sort of conflicts and wars that we are having. Like, for example, education, poverty levels, and the environment as well, which we all have seen it in different types of countries around the globe. To conclude on this point, in fact, all of these conflicts, I may call it global. Yes, they are local in origin, but they have a global impact in different countries. Impact on neighboring countries, impact at the wider region, similar to what is happening in IMRO, as well as the whole world. And without mentioning examples and cases for that. I'd like to just to move the second slide. Sorry, it is not moving. Yes. Yeah. Now, as a result of the above thing that I have mentioned, the above status, and unfortunately hidden by the COVID-19 that we have had for almost 2.5 years, at a global level, the number of the people needing humanitarian assistance globally has almost doubled. And I'll give you numbers. There are over 312 million people needing assistance across the world today, which is representing an incredible increase of about 86% since January 2020, which it is really very frightening. Between 80 to 90% of the humanitarian burden is due to conflict and war and political instability. Now I'd like to go to the EMR status. Yes. WHO Eastern Mediterranean region is composed of 22 countries that are from the Far East, Afghanistan, Pakistan, and Iran, to the Far West, Morocco, Tunisia, and Libya. And unfortunately, the region is a region of contradiction. 9 of our countries are directly impacted by conflict. 5 of these countries are host of a large refugee populations. And 9 more countries are experiencing major humanitarian crisis. While we are almost representing 9% of the total population as an IMRO region, unfortunately, we have 36% of the global humanitarian burden. It is really very, very heartening when we know that. And all the sources around, IMRO is also the source of around 60% of the world's refugees. Most of these conflicts, unfortunately, are chronic in nature, with little prospects. I must say it, I'm not pessimistic, but I must share with you facts. With little prospect of peaceful political resolutions in the foreseeable, near future. And we have reasons for that, to say that, including, but not limited to, Afghanistan, Syrian Arab Republic, Yemen, Somalia is another example, and the occupied Palestinian territory. The impact of communities is deeply troubling, as you have seen it in the TV channels through different, news. Over 30 million people have been forced from their homes, and many more are experiencing unimaginable losses of lives, of their houses, of their savings, and suffered injuries, different types of injuries, mental, physical, psychological, and have been pushed to be away from their homes, pushed towards the poverty line. Adding to the complexities I have just mentioned above, more and more fragile and conflict-affected countries are being hit by multiple hazards. And I'll share with you examples. Of the 41 infectious diseases outbreaks that have been reported, not including COVID-19 currently, which is ongoing, 28 of these 41 are really reported in fragile and conflict-affected countries, including vaccine-derived polio. In 2021, 5 of the 10 largest natural disasters that have happened around the globe, as measured by how many people affected, occurred in our region. 4 of these were in the fragile, affected, and conflict-affected countries. Climate change is another big challenge that the whole world is facing, and it is affecting every country. I'm sure you have seen the floods that hit California and other states in US, the flood that hit Pakistan, the drought that is in the Horn of Africa, including Somalia. Many children are dying because of the malnutrition. So it is really becoming a global challenge. It is a cause or a contributing factor for communal political tension leading to conflict. And a very good example is what has happened this year in Darfur, in the west of Sudan. People, 2 tribes fought with each other because of the drought, because of lack of farms, for their own animals. Worsening climate change conditions, more frequent, due to severe weather events, such as what I have mentioned happening in Pakistan. While the race, to be honest, among all countries around the globe, the race for more weapons to be bought is consuming huge amounts of resources, of money, of natural resources. Funds for basic social services and humanitarian needs remains very low and very scarce. Focusing on, which is pushing us to focus on prioritizing whatever priorities we have, including, civil population, women health, children, elderly, and other vulnerable groups. The first thing that I'd like us to share with you on this theme, we need to secure basic package of health services at a primary healthcare level, but at the same time also at a secondary healthcare level, in which people are dying because of lack of services for cancer, lack of services for maternal and child health, lack of services for many other non-communicable diseases that people are facing. More resources must be made available in fragile and conflict-affected countries, and there should be no difference in which part of the world these resources are really directed. Secondly, we need to strengthen surveillance and disease control measures so that we can prevent outbreaks occurring from the first moment it occurs, detect them as early as possible, and make the needed management and respond effectively when they do occur. Thirdly, the application of the principles of the humanitarian development peace nexus is a key. We consider it now and more than ever before. This starts with the prevention and preparedness, and it includes humanitarian response from day one that fully paves the way for sustainable recovery and better resilience. And we have started such movement in IMRO. WHO has learned how to translate this theory into practice in many countries. We hope that others definitely will learn from that and will follow the same pathway. Short-term and ad hoc humanitarian funding with only little strategic commitment and support in system strengthening using people-centered approach can no longer be a model for the future. Change is needed urgently, and we have to do it now, otherwise we will be losing lives. Fourthly, and last, we need to ensure that humanitarian development peace nexus is well coordinated beyond the political part of it. It has to go to the health system, it has to go to the societies and communities, engaging all UN and other non-UN agencies, in a very cluster approach. To integrate the sustainable development perspective in all emergency work and vice versa. And this is a very good example of using these sort of development projects to serve humanitarian situations. We have a very good success stories from Somalia, and we are copying it to Syria, to Afghanistan, to many other countries in the same way that we have done it. Another serious challenge that we are really facing is fragmented governance. And we have been working with member states to make sure that whatever resources that we have, whatever systems are really strengthened and resources are effectively and efficiently utilized. And without mentioning names of countries, we have multiple countries in the region in which we are facing that challenge, but we are working with them. Also, another ongoing challenge is the attack of the healthcare facilities. It is unfortunate to see that missiles or weapons are directed towards ambulances, hospitals, killing healthcare workers as well as patients and community members. To share you with in numbers, in 2021, there were around 360 such attacks documented in our region, which represent 44% of those attacks happening at a global level. It is really very sad to hear that. Before I conclude, Prof. Adnan, my remarks, I'd like also to share a few optimistic and promising success stories from the region. Yes, we face these challenges, but we have done a lot on that. In Afghanistan, for example, We worked on assessing over 900 WHO-supported health facilities in January 2022, which demonstrated that 99% were fully functional. I'm really proud of that. And this has come because of the very strong will and commitment of teams in WHO at the 3 levels, but definitely at a country level, supported by all UN and non-UN agencies, which is compared to 17% in September 2021. So there is a very big jump from 17 to 99%. And less than 1% had stockouts of essential medicines, down from 77% in 2021. In Iraq, for example, and occupied Palestine territory, our trauma programs have averted thousands of deaths, and I'm proud of that. In, with our collaboration with partners, the displaced person camps, of Northeast Syria Republic has resulted in reducing mortality rates within international standards. WHO also support nutritional surveillance centers in Yemen and Sudan, which resulted in cure rate of over 90% of severe acute malnutrition, well within the international standard. We are really proud of that. Now, coming to the humanitarian emergencies due to conflict are always political in nature. It is a fact, we must admit it. And health can be a bridge for peace using conflict-sensitive approaches, as I have mentioned, by extending services to the most vulnerable people, and thereby respecting their rights, as we are all calling all the time, the rights of the people to get health, education, and other services, and bring that social cohesion between the different communities and groups of communities, and resilience, as well as trust at a community level. But this means that we as healthcare professionals need to step up beyond our comfort zone. We have to go beyond our comfort zone. Otherwise, we will not be able to make a change. Taking health in all policies as a serious one, we have to call on our national and global leaders to stop the wars. They have to stop the wars. No more tolerated by us all. And that is the key message I keep sending to our ministers of health, minister of political affairs, or social, to engage them. I would like us to conclude by sharing our AMR vision, which have been established 2018 by my colleagues, and we have been working on it for almost 4 years. We have made a lot of successes. It is the health for all, by all. It carries the spirit of solidarity and making action on the ground, and it calls for creating and building healthier and better future for our communities, for our future generations, and make it really fortunate for the future generations to live in their world, starting from the climate, from healthcare healthcare facilities, health services, promoting health education, getting clean water, having safe food to live in, and prosper, instead of just living in wars and conflicts. Many countries are suffering from the current situations in Syria because of cholera, in Pakistan because of the floods and outbreaks of different diseases, in Somalia because of the drought, and many other countries are suffering from different outbreaks here and there. Thank you very much, Prof. Adnan. I'm sorry if I took this much time. Thank you very much.
Thank you very much, Dr. Al-Mandari. And we heard your call for stopping wars very, very loud and clear, and we'll come back to that point. It's my great honor now to invite Dr. Christos Christou. Dr. Christos is the International President of Doctors Without Borders. And for those of us who have been in the field of health or public health, Doctors Without Borders is representing not only, I think, a technical skill set, but also a moral skill set. It represents individuals who have gone beyond their call of duty, beyond their national borders to work and perform. And so I'm very excited to invite Dr. Christos as a surgeon, as a leader of MSF, Doctors Without Borders, to come and talk a little bit about his perspective on humanitarian health. Welcome.
Thank you for such a nice introduction, and thanks all for joining this evening. It is really my pleasure to be able to give this viewpoint of Doctors Without Borders, MSF, because we've been providing humanitarian healthcare for more than 50 years. And as a result of our global reach and the sheer number of projects we run, I think we can give you an insight of the situations that our teams see every day. I will limit my focus to 3 central points. More than 1/3 of our projects are dedicated to providing assistance to people living in areas of war and armed conflict, like Central African Republic, Iraq, Ukraine, Nigeria, South Sudan, Syria, Yemen, amongst many others. And these contexts are each unique with specific cultural, historical, and geographical factors, but we constantly bear witness to similar patterns of human suffering, to civilian casualties, and to the long-term degradation on healthcare systems. Time and time again. As a surgeon, I've seen this, be it whilst operating in Mosul in Iraq, in South Sudan, or in the greatly neglected conflict that continues in Cameroon. And this brings me to my first point. In almost all the situations in which we work, it is civilians who are bearing the brunt of violence. It is civilians who are bombed, killed, and tortured. It is civilians who are deprived of the most basic and essential services. And it is those same civilians who are often forced to flee. These same civilians who are then met with inhumane policies directed at people on the move. Just look at those fellow human beings of us who reach Europe and who face being stripped of their dignity or violently pushed back. And yet, within those heavily burdened civilian populations, we also see incredible acts of humanity. It is often the civil society who are the first responders and the last to leave. I just came back from Ukraine, where I met voluntary groups, and they are doing such an important and amazing work there. We see it in many conflict areas, but also elsewhere in Europe, where incredible acts of solidarity towards those fleeing have been performed by ordinary citizens, even as many European governments enforced policies to prevent people from seeking safety. At MSF, we see ourselves also as part of this global civil society, and our medical assistance is at its core an act of solidarity. And yet, as an organization, we are frequently delayed in providing humanitarian assistance due to multiple barriers. This brings me to my second point, which is that when it comes to access to healthcare in conflicts, time is of the essence. Any barrier that exists between patients and care is a barrier that causes suffering and costs lives. Doctors need to be able to reach patients, and patients themselves also need to be able to reach healthcare facilities. But often, state and non-state armed groups obstruct access with terrible human consequences. In the course of our work, we often see this weaponization of healthcare. It can come in the form of penalizing the same act of saving lives, and it can come also in the form of the targeting of health workers and facilities. We only have to look at the situation in Ethiopia these days, or the sinister legal challenges tried to prevent our MSF boat saving lives in the Mediterranean. I will never forget also when I was working in Southwest Cameroon, I was not allowed to transfer one of my patients, a gunshot wounded boy, to another hospital with an operating theater because I could be accused of assisting terrorists. So I was desperately looking at him dying. And this brings me to my third and final point. Whilst everything looks different in wars today, everything remains the same. We witness and experience direct attacks on healthcare installations and healthcare workers, as Dr. Ahmed mentioned before, and the situation remains unchanged, with violence against healthcare in a feature of conflicts from Yemen to Syria, from Cameroon to Ukraine. Attacks on healthcare workers and facilities unleash a chain of consequences. That consequence of the event has a devastating impact on civilian populations. Take the attack of the MSF hospital in Kuduz, northeastern Afghanistan in 2015. At least 42 people were killed in the United States airstrike, but that impact was just the beginning. The hospital was the only facility of this kind in northeastern Afghanistan, a well-equipped center of healthcare, a beacon of hope. More than 15,000 surgeries had been conducted there before its destruction. And the loss of such a facility was felt time and time and time again for the civilian population of the whole region. It must be said that there are laudable efforts these days from international bodies for greater respect of international humanitarian law and better data collection efforts coming from the WHO. I have to admit that. But we must also underline that attacks and violence and threats against healthcare are bringing deadly consequences right around the world. Not only people and installations are under attack. The whole concept of healthcare as an institution is under threat. Politicizing health and using it as a means to achieve a different political end is dangerous and undermines the most basic understanding of the health agenda. It's one thing to be political and another to be politicized, as you would agree. So we must refuse to accept or to normalize these impacts on civilians. Every party in a conflict must uphold the basic human decency to allow the wounded and sick to be treated. And the sanctity of medical treatment must be preserved, and it must come without compromise, without precondition, without discrimination, and to be accessible for all. So against this culture of impunity that breeds further violations of international humanitarian law, we must continue to affirm that a doctor in a conflict is not an enemy, is a doctor, and is there to alleviate the suffering, is there to save lives.
Thank you very much, Dr. Christou. Your statement that humanity suffers first and yet humanity responds first is amazing. And we're going to come back to that in a later intervention. I'm now honored to invite Dr. Natalia Kanem. Dr. Kanem needs very little introduction, but she's an Under-Secretary General at the United Nations and currently the Executive Director of the United Nations Population Fund. I'm really honored that you are participating in this panel to bring a population perspective and the perspective, obviously, of looking after many, many offices and organizations in many, many countries of the world. Dr. Kanem, a pleasure to have you here.
Well, thanks very much indeed. Gracias, Dr. Adnan. Excellencies, dear partners, dear friends. Urgency, emergency, rescue. That's our subject today as we consider how humanitarians can save lives at a time when 2 billion people are affected by fragility, by conflict or violence. And by 2030, half of these people will live in extreme poverty. In fact, as the war in Ukraine and conflicts elsewhere are showing us, the knock-on effects of violence in particular, things happening in one place resulting in significant aftershocks elsewhere in every corner of our world. Things like global food insecurity, right? That was made real. A precarious economic outlook and social pressures, whether high income, middle income, or developing countries. This is all clear evidence of the universal vulnerability that we all share at this point. And UNFPA, which is the United Nations Sexual and Reproductive Health Agency, working very closely with the World Health Organization and so many others coming under the umbrella of the Refugee Agency. In our humanitarian action overview this year, we show that more than half of the maternal deaths in the world and up to 70% of gender-based violence occur in settings where you have humanitarian and fragile conditions. Now, the face of a woman and a child is what we're discussing here. Because when you have war and conflict and disruption of public health services, including the provision of sexual and reproductive health information and services, you're leaving women and girls vulnerable to exploitation and to abuse. And those who flee in the first instance are that woman and her children. In Afghanistan, in Ethiopia, in Yemen, in Haiti, and so many other locations, we're also seeing the reversal of so many hard-won gains and how quickly they evaporate when the infrastructure, but also when the political will abandons people. Okay, there is a partial picture of promise, and I think we were able to hear a little bit about some of the realities that people do step up and that civil society, the medical community, and so many others, midwives in particular as well, try to cope. UNFPA is working in over 150 locations, and on the ground, our colleagues are right there on the front lines. And you do meet people like a young woman I met in Yemen earlier this year, who after so many miscarriages was able finally to access antenatal care and was very hopeful now in her 7th month of pregnancy that she would succeed in having a baby. And you know all of the social consequences that attend to this. But the challenges that we continue to face, the disruption, the collapse of health services, the rubble, which we saw hospitals targeted, attacked, healthcare workers, the lack of access, safe transport, and on and on. These are important conditions that can be planned for and ameliorated. Access and quality of care, right? I've seen the desperation of health workers who've literally been forced to work underground in shelters in order to provide care. Rape and other forms of violence employed as a weapon of war, heinous and must bear discussion and interruption. In this context, UNFPA is supporting the formulation of the implementation plan for a framework of cooperation to prevent and respond to conflict-related sexual violence, which was signed by the United Nations and the government of Ukraine just in May this year. But everywhere this is becoming to the forefront. Now, the other very protective and important thing in a humanitarian health setting is to trust the people on the ground to be able to deliver. At this point, 40% of UNFPA services and funding is delivered through a local population who understand the culture, the language, and are able to move swiftly. And here, whether it's obstetric, prenatal, postnatal care, providing modern contraception to women and adolescent girls who do not wish to become pregnant under the dire conditions that we're speaking about. And yes, avenues for safe abortion were legal and post-abortion care everywhere, because it's not just the physical health of the woman or of the girl. We're talking about her rights and her ability to recover after the trauma that she has been subjected through. So this is a global health issue, and the displacement, the violence, the attacks against health professionals, all of these are challenges that we can work together to address. So I would say that we need to pay attention to data, the disaggregated data that allows me to bring you credible evidence. And we have to, again, pre-plan. So having a plan to ask people, what did you face on the road on your way to where you are today? And where is it that you intend to go next? Again, so that we can have the impact that we want. It's crucial to be able to understand data, to know who's being left behind. Progress in building more resilient health protection systems. And for me, insisting that sexual and reproductive health should no longer be unspoken. This is actually a top priority for many women who are in dramatic conditions of lack, and they don't need to apologize for wanting a menstrual pad or for wanting someone to hold their hand and get them safely through a pregnancy, which, by the way, they might not even have consented to. So no apologies for sexual and reproductive health. Secondly, working with communities, as I've said, and actually as MSF also pointed out, is part of our success. And finally, solidarity. Women demand peace. We join with the concept that there should be peace in the home, peace in the community, and peace in the wider world. Solidarity, strong cooperation between countries and among partners. This is essential if we are going to mitigate the ordinariness of violent attacks on women and girls who are fleeing for their lives, to root out sexual exploitation and harassment and abuse in every humanitarian delivery setting. And lastly, to trust women with this precious, precious peace proposition, because there will be no development without peace. There will be no peace without development, and none of the above without health as a human right for all. Thank you.
Thank you, Dr. Khanam, both for reminding us that we are discussing a human rights issue, that we are discussing a gender issue. And yes, women demand peace. And I think women will lead us to peace as well. We will come back to that issue. And then, ladies and gentlemen, and those of you who are in the room, by the way, if you have an empty seat next to you, please raise your hand. We have colleagues who are standing. If you have an empty seat, raise your hand. Those of you who are on the wall, if you see a hand, please make your way there while I'm introducing the next speaker. Thank you so much. Especially if you need to sit for physical or other reasons, please make sure you have a chair. All of us online and in the room are concerned about humanitarian health. Many of us go out to do something. Some of us face risks while doing that, but very few of us actually get punished for it, face severe consequences. And I'm so honored to introduce our next speaker as somebody who made that transition from wanting to do something to actually doing it, to facing consequences, being a prisoner of conscience. You are a physician, a surgeon, an academic, a writer. Dr. Matira, I'm honored to introduce you from Myanmar to talk to us about humanitarian health.
Thank you so very much. I'm really modest and humble to be here. And I know I'm not in the position to represent any global institution, nor even my country. I simply represent myself. With this local experience, I will try to make the comments, local comments to the global system. And my first sentence, as humanitarian health is basic rights of human being, it could and should only be protected by humanity-based humanitarian system, not by regulation-based institutions in this war. Let me explain why I did this comment. I will just simply use my local experience. We have a military coup in February 2021. After that, the internal UN rules for the UN country team, UNCT, engagement in the post-coup context, saying that official meetings and public events with senior officials newly appointed by the de facto authorities should be avoided. Have The international aid agencies acted on its own internal rules in the case of war and conflict in my country, Myanmar? Unfortunately, the answer is not really. In August and September 2022, very recently, the UNOCHA, UNICEF, UNFAO, UNIOM, all these agencies signed new agreement and presented credentials to the terrorist military coup junta, which is called itself the State Administrative Council. On the other hand, the UN Residence Coordinator and the UN heads of agencies have not yet publicly engaged with the National Unity Government, which is founded 2 months after the coup by both elected members of parliaments of 2020 general election and intellectual dignitaries from ethnic and civil society organizations. Military junta is waging war against civilians and has been known to use its infamous four cuts policy to prevent any food, medicine, fuel, information, or aids to reach the territories that are regarded as supporting the resistance. And that areas are today over 80% of the country. Myanmar is now recognized as one of the most dangerous places for health workers. After the coup, targeted atrocities against health personnel, facilities, services, and commodities in Myanmar have reached up to 1/3 of its global total. A stethoscope became an evidence of anti-military protests as less than a dozen medical doctors led the civil disobedience movement, CDM, and it brought about 60,000 healthcare personnel joining it. At least 36 health workers has been killed, more than 500 had been arrested, and at least 126 raids on hospitals and clinics has been recorded. The Ministry of Health of the National Unity Government has been running 167 frontier healthcare facilities, including a mobile operation theater, 51 temporary hospitals for secondary care, and more than 250 mobile clinic teams in the war and conflict areas by its volunteer CDMOs, which includes around 250 specialist doctors, more than 400 general doctors, more than 500 nurses, and more than 2,500 basic health staffs and volunteers. Today, more than 60% of total 330 townships have township health administrative team under Ministry of Health of NUG. It also has online healthcare services, and since its launching in June 2021, Telejama Clinic has been operating 20 Telegram channel clinics with 36 specialties, and at the end of July this year, there were almost 90,000 visits from 319, almost 99% townships in Myanmar and other 21 countries where the diaspora and migrant workers from Myanmar live. Obviously, the root cause of humanitarian crisis in Myanmar is the military coup, and the culprit keeps committing all unimaginable crimes against humanity. Therefore, the people of Myanmar raise a lot of questions and concerns about what the UN is doing in coordination with the junta and not with the NUG, National Unity Government. We need transparency from the international aid agencies. What will these organizations do and under which condition? What kind of constraints they have accepted to follow? How will they implement their agreed activities? And with whom will they do their implementations? In conclusion, based on our own experience, I would like to stress that in terms of humanitarian system, especially in times of war and conflict, the international aid agencies should be transparent with the severe population be aware of root cause of the humanitarian crisis, and be logical to understand that the impartiality or neutrality cannot easily be defined as humanity. May I repeat, as humanitarian health is basic rights of human being, it could and should only be protected by humanity-based humanitarian system, not by regulation-based institutions in this world. Thank you so much.
Thank you, Dr. Matida, not only for your moral support and your solidarity, but also for reminding us that progress will only be made if we become uncomfortable. And you're beginning a difficult conversation. And we're going to have a few minutes of difficult conversations, just to warn all my panelists, because it is only by having uncomfortable conversations that we will grow. Thank you for that. I'm now honored to welcome by internet, and I hope the internet connection works, a voice from Ukraine. I think a conversation on humanitarian health today will be incomplete unless we have input from that disaster, from that humanitarian health situation. I'm honored to welcome Her Excellency, the former First Lady, Katerina Yushchenko from Ukraine. Do we have Her Excellency on the line?
Good afternoon. I wish to thank you for the opportunity to participate in this panel of the World Health Summit. This particular panel on humanitarian health in war and conflict is in the Africa section. But wars take place around the world, and wherever they happen, they bring death, destruction, and misery, especially to the most vulnerable segments of the population. As we all know, over the last 8 months, the Russian escalation of its colonial war in Ukraine has caused one of the world's fastest growing displacement and humanitarian crises, and its geopolitical and economic ramifications are felt around the globe. Ukraine is a huge supplier of food to the world, with many countries, particularly in Africa and the Middle East, receiving almost all their grain from Ukraine. Indeed, about 500 million people in the world are fed by Ukraine. The destruction of harvests and agricultural infrastructure and agricultural transportation have caused hardships and food insecurity far beyond Ukraine. Prices of wheat, sunflower oil, and many other products have surged. Even before the new Russian invasion, Ukraine's health service had been stretched thin by 2 years of COVID and by the occupation of Crimea and 8 years of war in Donetsk and Luhansk that had already caused thousands of deaths and massive internal displacement of close to 2 million people. During this time, our government had initiated major reforms in our healthcare system, which were intended to overcome the debilitating effects of the entrenched and lingering Soviet system. Thus, the creation of a national health service and the system of family doctors, as well as a system where money follows the patient, has kept the health system running even in the most difficult months of our war. The massive escalation of the Russian invasion into Ukraine in February of this year has caused about 7 million Ukrainians to become refugees abroad and has displaced between 10 and 12 million people inside the country. The invading army has specifically targeted medical facilities for bombing and shelling. In August, the World Health Organization said it had recorded 445 attacks on hospitals and other healthcare facilities, which directly resulted in 86 deaths and 105 injuries. 144 medical buildings have been completely destroyed, while 1,091 have been damaged. Our national and local governments have renewed 86 hospitals and partly renewed 208. The value of the medical buildings destroyed and damaged amounts to more than $1 billion. Hundreds of pharmacies have been damaged or destroyed, and hundreds of ambulances have been damaged or captured. There is a lack of many needed medicines, such as antibiotics, insulin, and other critical drugs. Civilian medical personnel have been killed and injured in the line of duty. Many doctors are displaced and working in other areas, leaving patients unattended in the occupied areas. This is especially the case because more than half the doctors in Ukraine are women, and they have fled war zones in order to protect their children. Some went further west within the country, and about 1% went abroad. Among those who remained in the stricken areas, many mobilized to help the fighters on the front lines. It is mostly the elderly and the chronically ill who, rather than evacuating, have stayed behind in occupied areas and areas of active hostilities. Indeed, we are not able to completely assess the health situation in the occupied areas. The Russians have refused to provide humanitarian corridors, thus not allowing treatment, medicine, and food to get in, or the injured and sick people to leave. On the front lines, there are many settlements that are regularly bombed without properly functioning hospitals and the necessary number of doctors. Doctors have had to work in the field, operating in unsterile basements and bomb shelters, sometimes around the clock. Recently, Ukraine has been able to regain territory and deoccupy lands in the Kharkiv, Donetsk, and Kherson oblasts. When we entered these territories, we encountered horrific destruction and losses that the occupation had brought. This has included ruined hospitals, clinics, schools, residences, utilities. Most of the medical technology and equipment was stolen. Cynically, the Russian army stole ambulances in one area and then gave them as so-called humanitarian assistance in other areas. Russian forces have hidden landmines across the country, keeping refugees from returning home and endangering farmers planting their crops. Ukraine is party to the Ottawa Treaty banning anti-personnel mines. Russia is not a party to the convention, has been documented placing thousands of these booby-trapped explosives. Traps have been hidden in utility hubs, food facilities, car trunks, homes, washing machines, hospital beds, and in toys and children's playgrounds. Many have been placed in dead bodies, specifically targeting doctors and emergency personnel who come to treat victims or to take the bodies. The use of mines is also exacerbating the global food crisis fueled by Russia's war. Farming in Ukraine has become dangerous as farmers trying to sow their crops have been blown up by Russian mines. The war has also burdened the medical systems of European countries that have been taking in our refugees, most of whom are women and children. We are grateful for the medical treatment they have been providing to them. About 2,000 seriously injured and sick patients have been evacuated abroad through the Medevac system. We expect that this need will grow significantly in the upcoming winter months. We understand that the targeted attacks on Ukraine's energy system and the energy
I'm afraid I think we've had some internet connection issues, so that is about as much as we could get from Her Excellency. I want to thank the former First Lady Yushchenko for that intervention. Clearly, the saga in Ukraine is continuing. This is an ongoing conflict and joins the many other ongoing conflicts that our speakers have highlighted and the plight of people there. So thank you very much to the First Lady. And if she can reconnect, please let me know. We will bring her back into the conversation. I want to thank all the speakers, but now I think let's try and get some input from you all. Oh, is she back? Lady Katrina, do you hear me?
I do hear you. Do you hear me?
Yes, yes, we do. Thank you very much for joining. We've just heard parts of what I think were partly recorded message. May I say, would you like to provide a minute of closing comment or closing reflection? We've heard most of your talk.
Yes, I heard most of my talk. I truly apologize. This is the situation in which we live in Ukraine now. Our infrastructure is bombed, and so we often lose our electricity. And I heard all the incredible speakers before me, and I want to thank them for all that they have done. And Doctors Without Borders is without a doubt one of the greatest organizations in Ukraine today. And so I know you have heard most of my talk. I wish I could have finished because I had pre-recorded a talk just in case this happened. I think you heard about 2/3 of it. But I think that the important thing that we know is that war is brutal and devastating wherever it happens. And it's essential that the world community reach out and support each other, all nations and all peoples, to bring an end to the imperialism, colonialism and the principle of might means right when it comes to borders, to end tyranny that are inevitably accompanied by destruction, injustice, corruption, kleptocracy. And we Ukrainians will remember everyone who stood with us now, and we are truly grateful, and we hope to help in the future. On the previous speakers, I want to say that indeed rape has been used as a weapon in Ukraine, and I thank you for all your support in that. And in general, thank you very much for the tremendous support that we have received. I wish I had had the opportunity to really speak.
Thank you so much. Thank you. And of course, on behalf of the global community, we stand with you, we stand in solidarity, and we hope that there will be an end, a very positive end soon. Please stay with us as long as your internet connection allows, and hopefully we can engage you as well. But I was going to turn to our audience, our wonderful audience here. Do we have a roving mic that could go and take a few questions? Please put your hand up, and let me give you an instruction. If you take more than 1 minute to ask a question, I'm simply going to stop you. The most effective question is a short question that will stun us and force us to think a lot. So think about 60 seconds, the most powerful question that you have, let it come from your heart. I'm going to take 2 or 3 questions and invite panel, and I'll see how many rounds I can do. Okay, let's start with the young lady there. Yes.
Yeah, hello. Thank you all for being here, for reflecting how the war really affecting the humanitarian situation and the people's health. I'm Tahani from Yemen. I'm a public health professional with a medical background. My question for Dr. Ahmed, actually, last week there were death of the 18 child cancer patients in hospital in Yemen. And that was because they were injected with expired chemotherapy drug. So, yeah, you know, the war is not the only one reason for killing people. Like even like having these drugs, they ended their life. So, and you know, the WHO in Yemen, they have the biggest role for providing the health, the healthcare for those people who are suffering a lot. So, where the role of the WHO and those really who have the role for example, yeah, I know there are many are accountable for this problem, but your role for corruption and those
important message. And by the way, thank you for coming from Yemen. Very important. We are very concerned about. May I have the young lady right here get a question from her? Yes, if you could stand up. Yes, go ahead. I'm going to take 2 or 3 questions and I'll ask the panelists. And
thank you so much. Since most of the panelists are engaged in a way or another in the humanitarian coordination mechanism, I have a question and reflecting how far do you think the existing humanitarian health coordination mechanism are efficient in addressing today's acknowledging based on the reflections from Dr. Ma, and how we can go forward, to be honest? I think this is the biggest elephant in the room. Thank you.
Thank you very much. Yes, you can actually give it to, no, in front of you. Yes, yes. Please go ahead. Please stand up.
Hello, first of all, thank you very much for a really insightful panel. My name is Goshan, I'm from Kurdistan. And as most of you probably don't know, we are a nation that has had to deal with generations of conflict and turmoil and violence. My question is something that was slightly addressed earlier, but I want to just pinpoint on it. To what extent does the humanitarian community have the flexibility to have, I suppose, ambiguity in which particular side they actually favor when it comes to humanitarian aid? When we have conflict, there is always 1 or 2 sides that are fighting each other. To what extent can we actually allow the humanitarian agencies to have a certain level of, I can't think of the word right now, but, you know, political.
Thank you.
Yes, I hope that was clear for you, but yeah, thank you.
I'm going to stop there for a minute, and we have 3 questions that I'd like to generalize those questions. We have a question of how can we avoid doing harm when we respond to humanitarian conflict, right? The do no harm principle. We have a question on efficiency. Are we confident that our responses are efficient from the various organizations? And then we have a question of neutrality and objectivity. And how do we maintain neutrality and objectivity? I'd like reflections actually from all of you, starting with Dr. Mandhari, you.
Thank you, Adnan, for rephrasing the questions, and thank you, colleagues, for this important one. In fact, just I'd like to share our own personal, IMRO personal experience when it comes into making sure that we do not, make harm to the people when we go for humanitarian. But the challenge that we are facing there, as within the same country, there are different groups fighting with each other. In addition to countries, coming into this international. There's one message that we have sent to all leaders in these conflicting groups that we as a WHO and other UN agencies, in fact, myself, I have expressed it when I visited Yemen in 2019 to both sides, to the legitimate government, the Prime Minister in Aden, and to the Prime Minister in the, de facto government, that we as WHO and UN agencies, we serve Yemenis regardless of their locations, either the center or the peripheries, regardless of their political, social, religious, affiliation. That was the key message. But in spite of that, we are still facing a lot of difficulties on the ground. Thank you.
Thank you. Dr. Khanam.
I'd like to reflect that, in a month, we'll be announcing a world population increase to 8 billion. If 2 billion of us are living under these circumstances, it shows, sadly, that the principles of international humanitarian law, which the Secretary General upholds time and again and reiterates time and again, have to be taken seriously. So I think the matter of accountability versus impunity, which also Dr. Mashida put on the table, is something for us to arbiter in every instance, because we don't know what's going to happen tomorrow. But I think definitely the concept of the problem of the other neighborhood no longer makes any sense. So I think much in the same way we look at the pathogen, the bacteria, the virus, whatever, this question of instability, breeding instability, we have to take seriously. On the question of efficiencies, the honest answer is no. And part of the reason why we appreciate this meeting today is, like I brought the data aspect of planning, but I could have stressed coordination as much. Why step over each other? Why not work in concert? Why not have division of labor? And I think we need to do better on that aspect. And just to close on the aspect of neutrality, it is troubling if you're working in Afghanistan, as UNFPA does. I think we heard the Myanmar circumstance. We are sworn to save life in whatever way we can. And this principle of neutrality, which we uphold, does give you strange circumstances where you have to cope. But our insistence through the Secretary General and through every arm of the United Nations is for combatants to cease, for the principles of international humanitarian law to be upheld, and in particular, that access to be able to deliver care should always be protected, which again is violated on a daily basis, but the insistence has to be there. Thank you.
Thank you. Dr. Christos.
Well, actually, it's so difficult to answer these questions because we keep asking these questions to ourselves every day in all our missions and our challenges. And maybe I'll try by saying that doing no harm and being effective are two things that always bother us a lot. And the answer here is you can do it differently by engaging more with the communities. We have seen all these years that putting the patient on the center of our interventions is not enough. Listening to the communities and getting challenged by them is a big new challenge for all of us. And I invite everyone to join us in really trying to listen to them and follow and design together the ways that they would like to see our help. Becoming more effective. In order to become effective, first you need to gain access. And in many places, I repeat what I said before, it's so difficult to negotiate access. And in different contexts for different reasons. Myanmar is an example. Ukraine is a different one. Cameroon, as I described before, or northeast Nigeria these days is a different, but still for MSF, and I think every medical humanitarian organization, what matters is to be able to negotiate with all sides in order to be there where the patients are. And this brings me to the last question about not just being effective, but this notion of neutrality. You said that, Professor, that everything that we do is political. We make choices every day, and we know that. So we don't have this illusion that we're neutral, but the spirit of neutrality is always a guiding principle. What is more important, though, is this notion of impartiality, how impartially you address the needs of the people, and you are there where the needs are. That's how we look at it.
Great point. Thank you, Dr. Christos. Dr. T.
I might say the transparency again. I think transparency can bring more engagement and cooperation from the local community that can make us more effective way or do no harm anything. So yeah, we really want the transparency from any entities, not just the International AIDS Agency. That also help us defending our right to information and defending our right to claim the no more impunity. Thank you.
Ms. Yushchenko, did you hear those questions? Would you like to come in?
Thank you, I did. On the question of efficiency, I'd like to say that, you know, we're really grateful in Ukraine for the extraordinary mobilization, crisis response to the health emergency that we have seen from partners around the world. Whether they are countries like Poland, which has shown tremendous logistical efficiency in receiving our people, and where they've taken people into their homes. And I would like to see that truly around Europe and around the globe, where it's not just by international agencies, but you see it happening in families and in individuals. We have seen it in NGOs such as Doctors Without Borders. We've seen it in international organizations such as the World Health Organization. While we have complained, I have to say, about many international organizations not doing their role, the WHO has delivered a great deal in terms of specialized medical supplies, the deployment of medical teams and their coordination, has worked with our health authorities to minimize disruptions to the delivery of our healthcare services. So, you know, I think that we have learned a lot over the last months in terms of what can be efficient. And one of the most efficient ways we have found is that it is varied. Some comes through international organizations and some comes through the huge numbers of NGOs and crowdfunding that has been characteristic of our work. And on the neutrality issue, that's been a very difficult issue for us. We have tried to be neutral when it comes to health. All our doctors have been told that they are to treat all patients, no matter what side of the war they are on. But for example, when it comes to humanitarian corridors, we have not received the same support. When it comes to asking the International Red Cross to visit our war prisoners in Russia, we have not seen that neutrality. We have not been able to see Russia giving access to international organizations to give our prisoners and our patients there and all the hundreds of thousands of people deported that same access.
Thank you very much. I'm going to take another round. I want to try and get some more, and I'm going to go at the back. So people in the last row, they always get left out. Yes, the young lady there, please go ahead. And short question, 60 seconds is your time to ask a question. Please go ahead.
My name is Sophia. I'm a psychiatrist from Ukraine, and I have a question concerning cooperation. What we found out, I'm a part of humanitarian project launched by Germany. We found out that there are a great number of projects we don't know about. So there is a bit of lack of cooperation between the projects, and these projects are quite interfering. I would say what I want to raise here is whether we want to collaborate and coordinate all the projects, for example, for Ukraine, because we're doing the same things at the same time, and we could be more effective. Thank you.
Thank you very much. I need to see hands. Let me take a question on the left here. There's a gentleman. Yeah, why don't you stand up, sir? Yes. So my colleague will see you. The microphone will come to you. Thank you.
Thank you, Mr. Moderator. My name is Jürgen Focke from Helpage Deutschland. Very quick question, please. We are talking about vulnerable groups, female, children. Nothing should be taken away from them, but there are some other vulnerable groups. And especially if we talk about Ukraine, these are persons with disabilities and older persons. And so far, it's sometimes called the oldest conflict in the world, because more than 50% of the persons and people there are over 60 years old so far. So my question is to the representatives here on the panel, how will you prepare yourself or your organizations in the future to contribute the needs of these vulnerable groups like persons with disabilities and older persons in your future?
Great question.
Sorry.
Great question. I got the gist of it. Thank you very much. And one more, actually right in the middle. Yes, sir. If you stand up.
My name is Mulugeta. I'm pediatric infectious specialist doctor. Originally,
Little louder.
My name is Mulugeta. Originally, I'm from the northern part of Ethiopia, Tigray, which is a war zone now. As you all know, in Tigray, currently more than 500,000 people died because of lack of medicine, malnutrition, because they are denied of all health facilities. They are under total blockage. Personally, I lose my mom because of lack of medicine. She died last year and not contact family. So my question is, like, as humanitarian agencies, what's your role in terms of reaching these people, because they are denied?
Thank you.
All,
Yeah. Thank you, and our condolences on your loss. Losing a mother at any time is difficult, so our condolences. I'm going to stop here because of time. Dear panelists, we have questions around this notion of collaboration and coordination, which Dr. Khanam raised earlier, on the notion of expanding our definition of who's vulnerable. The disabled community, the elderly has been raised. And then this very important notion that when people are denied healthcare and access, people die. And this is happening in parts of the world, one of them as an example. Do we still have Ms. Yushchenko online? No? Okay, we're going to start this way. So Dr. Tida, first comments on those three issues, and you have 2 minutes each.
I think the issue of the vulnerable, that's really very much important to make all of us to focus on whom and which population we are, we need to take care of it. So that's the pretty much obviously we having saying the vulnerable group and protected group, we name them a lot of the women and some other minorities has been recognized as the vulnerable groups already, but of course we still do need some more in-depth understanding about in which condition, not just the name of the group of people, in which times of the situation, something like that. That should be, we need to focus on. And I don't remember some. Yeah.
Coordination.
Yeah, coordination. Of course, the coordination is the most important and not just the solidarity. And that's in that sense also to gain the effective coordination, the transparency and interagency trust is very much important. So I just see, yeah, we still, I'm the one who really wants to protect for the right to information for everybody.
Thank
you. You ask MSF about coordination. Maybe we have last to advise on how. So far, all these 50 years, we had in our mantra this way of operating, which was to meet the urgent needs immediately and go there solely and vertically. However, we understand that the modus operandi of today must be different, and we are more open, not just in partnerships, but also in coordinating with others that they are present in the field. Of course, sometimes I need to still accept that we barely find others in the places where we are. And this is a call and an ask for all humanitarian NGOs these days to make sure that with more senior staff, they are more present in those areas, like our colleague mentioned before, Tigray being one of them. Vulnerabilities, of course, and this pandemic showed to us that there are pockets of vulnerable people and people excluded everywhere. So especially in conflicts, it's not difficult to imagine what kind of vulnerabilities this could be. And we're extremely worried these days, for example, of a chronic non-communicable diseases in Ukraine. But we're also extremely worried about the very basic essential needs diseases in all other places. And I don't know if I will have the time later on to talk about this at all, but yeah, the question of the Tigray and the access is what I'm extremely worried and bothered. And it was one message that I would like all of you to take back home from this room when we finish. But let me also say that with all the respect to how the population in Ukraine suffer these days, we should not neglect so many other humanitarian crises that they are just to name a few. In Yemen, nothing has been evaporated or stopped just because our eyes and our minds are with the Ukrainian people these days. In Tigray and the whole Ethiopia, the same. There are people in detention centers in Libya that they live in slavery conditions. There are people stranded in mega camps, like in Bangladesh, in Cox's Bazar, in Dadaab. There are people that they get drowned in the Mediterranean Sea. And there are people in other protracted conflicts, like what is going on in Afghanistan, that we don't see. So at least let's leave this room with this clear message. Don't forget all these neglected crises. Don't forget all these neglected places.
Thank you, Dr.
Well, thanks so much for the questions on the coordination issue. I believe that at this point, we have the advantage of many of us having been there before, during, and after the issue. And while we focused a lot on conflict today, the climate issues also deserve attention in terms of pre-positioning and planning. And I totally agree that we have to do better. I think that there are shared platforms now for being able to, remove some of the barriers around the silos, but we have to work with communities in order to achieve that. For UNFPA, having been there before, planning for the actual event and then being there afterwards has been a huge advantage for learning. I just want to subscribe 100% to the question on different types of vulnerability. In our strategic plan, we actually address disabilities, but again, there's so much variety of types of disability. The best instance is using the communities affected, and I think we've all reflected that in our remarks, to be able to plan properly, to evacuate people, to cater for them. The elderly population has not been looked at as much, but that does deserve mention. And then for the access issues and the importance of not targeting health workers, of allowing us to be able to devote the attention, I just want to say very clearly that this is a noble proposition. The humanitarian who straps on that backpack and gets on a plane and is willing to cross to the next village, to go up the mountain, to go across the island, needs to be praised, yes, but also to be supported. And access is part of that support, and a decent ability to do your job and then take a rest and detox and look after your own mental health is part of that. So I want to express a concern and a thank you to those of you who are working on the front lines. You have my total admiration. Thank you very much.
Thank you for the questions, and my comments and remarks will be, in fact, about coordination, serving the vulnerables, and therefore improve the access. And I'll share with you examples of two countries I have visited last month, Sudan and Syria. In Sudan, I went to Al Jazeera state, in which they have, in fact, in one of the small villages there, a camp for refugees, and many of them are from Tigray. We have been working closely with UNHCR, with IOM, with donors and partners to make sure that these camps are fully supported with healthcare services. They have a health center with the basic essential services, including maternal and child health. Yes, it is not optimal. We are facing a lot of challenges, but we work closely with the health authorities in Sudan to make sure that the government hospitals are also supported by WHO and other partners and make it really accessible for services. Another example is from Syria. I was in Dar'a last month, and you know how much Dar'a is really at the heart and the center of the fights with different groups. In that small village, I went to a health center which we as a WHO rebuilt, and I was really proud to see it among within the middle of many buildings demolished during the fight. We agreed, we made a contract with one of the national NGOs to run the health services in that center. And I was really proud to see that the center is really crowded with many people, children, mothers, fathers, adults, to receive the service and providing, if I may call it, state-of-art of services at their level. So these are two examples of coordination, serving the vulnerables, and therefore making health service accessible. Thank you.
Thank you very much. So, ladies and gentlemen, with 7 minutes left, here's what I think will be appropriate. I'm going to give 30 seconds to each one of my colleagues, maybe a minute, let's say. A minute to each one of my colleagues to respond to a question I will pose, and also any opening final word. I believe that the responders in humanitarian issues need to be held to a higher moral standard than those who are affected by those humanitarian health concerns. So when we look at NGOs, be it MSF, Doctors Without Borders, or UN personnel who are then accused of racism or sexual violence or other types of violence themselves, it really hurts, because responders are meant to help, not become perpetrators themselves. There are now enough viable reports of these types of things happening. I'm concerned about that, equally to the attacks on healthcare workers as well. But I think this is an issue that institutions have to face. This is the role for organizations to have very strict policies, very impartial analyses. I think many of us are not happy right now with how this is being considered. So that's my challenge to you. I give you a minute each to talk a little bit about the topic that I've raised. I know it's insufficient, but I didn't want the session to end without addressing the fact that those who respond need to be held to a higher moral standard. Dr. Mandari, from you first, and we'll move this way for a minute each.
Thank you very much, Adnan, for bringing this in a very brave way, and I'll give you a very transparent answer based on WHO experience. WHO learned the lesson in a very hard way, if I may call it, without mentioning examples. And that's why, in fact, for the last 4 to 3 years, member states are really asking us as a WHO to create a system to make sure that our being as civil servants, are really working according to legal, professional, and ethical frameworks without endangering the lives of those whom we serve. So that's why WHO, in fact, created 2 years back a system or a body within WHO. We call it Prevention and Response to Sexual Exploitation and Abuse at a global level, with a very strong professional team at a global level, regional level, and we selected few countries that are prone to such, sort of behaviors in each region. From EMRO, we have identified, 5 countries. We are in the process of recruiting 1 coordinator at a regional level with 5 staff in these countries to make sure that, staff are really initially well-oriented. We have started orientation program. We created a policy and procedure for these sort of things so that staff do not feel, even those whom we serve, do not feel really frightened or threatened to report it to WHO. And we strengthened that system. We created a fast-track system to make sure that we are efficient when we deal with these sort of, bad things. Thank you very much.
Thank you very much. Dr. Khanna.
Thank you very much, Dr. Adnan, because it's absolutely true that as humanitarians, we must be held to the highest standard. And as I mentioned in my remarks at the podium, the betrayal of, in particular, sexual exploitation, abuse, harassment of the people that we're meant to serve is egregious. And in that line, I believe that the human rights proposition has to be reinforced so that the power dynamic, the type of fear of retaliation, the expectation that you should exchange whatever for sex has to be exposed. And in order for that to happen, the woman, the girl, the man, the whoever it is, has to have confidence that the system will respond. And this is why I also spoke about impunity. We have to call people to account. It is no longer an era where you can brush this under the rug. And there is no greater solace to someone who has been wronged than to have the justice system stand up for you and give you redress. So the question of courage to report doesn't arise. It shouldn't take courage for me to be able to assert my human rights. So I believe that a lot of the exploitation that you're describing has its roots in a gender dynamic, frankly, that even on a normal day, when it is not a conflict situation, women are told to be quiet. Girls are told to keep secrets. So it takes all of us. And I think it also takes the example of leaders, male, female, whatever, who are willing to speak out and name the problem. And this is why I appreciate you using it as our final question. Let's put a stop to this. Thank you.
Dr. Khanna.
I'm going to build a little bit on what Natalie said before, because it is a lot about this power imbalance between those that they provide the aid and those that they need it. And this imbalance becomes even wider in conflicts, in protracted, deteriorated situations like the ones we saw the previous hour. And there, I'm sure that we all need to do more. But a first reflection from our side as MSF is that coming closer to the communities can help them gain the trust. And by really intervening with all this humility, it will make you understand that this whole power is just an illusion. So I come back to this comment about community engagement, which I think is the main challenge for us these days.
Thank you. Thank you. And Dr. Tita.
Yeah, the morality issue is ever been challenged to any institutions. And I think until and unless we all are the active, responsible global citizens, we cannot solve that problem easily. So of course, we do need some regulations and principles and policies, but I think individuals also have very needs to commit to the morality. It is a ground rule. It cannot be in the policy, but it should be in the practice. Thank you.
Ladies and gentlemen, it is 5:30. I would love to continue, but time's up. So let me end this session by saying we must stop wars. Women are demanding peace. People are the first to be affected, and they are first to respond. And we stand for our conscience. That, ladies and gentlemen, is a summary of this extremely complex issue of humanitarian health. Each one of you has the power to do something. And I hope that leaving today, each one of you, whether it's a few minutes or the rest of your life, help us in getting rid of this particular issue. Thank you very much.